Dr Ron Trubovich is a New Zealander who initially specialised in anaesthesia, obtaining his fellowship in England in 1966. On return to New Zealand in 1968, he became the Deputy Medical Officer in charge of the Acute Respiratory Unit, later to be renamed the Department of Critical Care at Auckland Hospital. From that time on, he specialised in intensive care, then an entirely new medical specialty. He has seen many changes throughout his productive career. He has presented and published widely, nationally and internationally. He has sat on many distinguished committees, and among his many awards is an Officer of the Order of Merit of New Zealand, awarded in 1997.
I had qualified in dentistry before I did medicine.
Oh, really? Okay.
And when I was working in dental practice at Huntly, for my cousin, I did quite a few gaseous anaesthetics, nitrous oxide and oxygen, for extractions, usually on children. And that seemed a good activity.
And was that how your interest in respiratory care started?
No. When I was going to England, we came from Dunedin up to Auckland, and I had a friend, also a dentist become doctor, who told me about the acute respiratory unit at Auckland, and he advised me to go and have a look at it. And I did it, and spent several hours with Matt Spence and saw the kind of patients he was treating, and learned about the results he was doing, and it seemed a whole exciting new field of medicine. So I went off to England, and after I'd been there about 18 months, he sent me a letter saying, "Would you like to work with me?" So I grabbed that. So when I came back to Auckland, that was what that was my employment.
So you started at the respiratory care unit in Auckland
Yes.
Hospital, which then eventually became a critical care unit, but it must have been a very different place then to the modern intensive care units. Tell us what it was like.
There was a large paediatric component.
Okay.
There was no paediatric intensive care other than what we could provide then, and what they could do in the infectious diseases department for simple croup that didn't become complicated. And when I look back at the figures, overdoses form the biggest
Really?
proportion of our admissions, yes, but there was a lot of trauma patients. Motorcycles were very popular in those days, and some dreadful things happened within. But that population is rather different from how it is nowadays.
The equipment that you used must have been very different. Tell us about
Well, you would regard it as pretty primitive. We had the usual endotracheal tubes and tracheostomy tubes. We had East Radcliffe ventilators and some bird ventilators, except we called them respirators in those days.
Yes.
As well as respiratory, there was circulatory attention. And Matt was rather a tiger for giving plasma as a cure-all for everything in circulatory troubles. That's changed now too.
And you wouldn't have had a lot of electronic pumps or anything like that then?
No, we had blood gas analysis.
Okay.
And we had one datascope which would give us a picture of the heart rate of a patient.
Okay.
There was one in the unit. Yeah.
How long did it take to do a blood gas on your machine then?
5 minutes. It was a radiometer, ABL1 we had then. It had become reasonably sophisticated by then, since they first started out. They produced their first clinical pH electrode in 1952, 53.
Okay. What about the monitoring that you used? I seem to remember even when I started you had to make your own transducers up. We didn't have that.
There was pre-transducer time, a blood pressure cuff and a pair of fingers on the pulse.
Okay. So there was no electronic monitoring of blood pressure, central venous pressure?
Oh no, not for a while.
Did you put a lot of central lines in back then?
A reasonable number, yes. Favoured the subclavian route till we learned about the internal jugular vein, and became very adept at doing those, yes.
And you mentioned endotracheal tubes. Were they red rubber tubes you were using then?
They were pre-plastic, yes.
Yeah.
Oxford tubes were the ones that were favoured. Didn't kink easily. The shape of them fitted all right.
Yes. And how long would you leave people with a red rubber tube in situ?
Well, if we thought we weren't going to get it out after 4 or 5 days, they'd have a tracheostomy.
Okay. All right, so
and then Portex turned up after a few years with their plastic ones, and then the low pressure cuffs.
Yes, and changed everything then.
I got involved during the 80s. I applied for and was granted a fellowship of the Faculty of Anaesthetics of the RACS in 1981, and it was one endorsed in intensive care.
Right, okay. And that was a fairly new specialty at that point, really. We were just in the process of deciding that intensive care maybe needed to be a specialty of its own.
Well, the intensivists were pretty clear-sighted about that. We thought of ourselves as a separate group. When you consider who the intensive care physicians in Australia were at that time, John Cade, Bob Wright, 2 or 3 others, you know, they had no interest in the course in the Faculty of Anaesthetists.
They were all physicians?
They were all physicians, yes.
And yet a lot of anaesthetists were working in intensive care at that time.
Yes, not so many full-time, a lot were part-time. And there were New Zealand physicians, Barry Nelson and a chap at Gisborne, whose name I can't remember now. They were physicians who part-time did intensive care in New Zealand.
So did that lead to problems when it came to creating a specialty of intensive care between anaesthetists and physicians, or who should be responsible for what, who the training? Or
in the 1980s there was discussion between the Faculty of Anaesthetists, the RACP, and the RACPs formed one of their SACs, Specialist Advisory Committee in Intensive Care.
Mm-hmm.
And that group was strong in ANZICs,
mm-hmm.
and of course the anaesthetists were stronger in ANZICs, and that was a group that formed between the two. It was a long time in Australia before intensive care was recognised as an independent specialty.
Yes.
No, but I became an examiner in the late, well, if I can go back a bit, I decided to join the section of intensive care in the Faculty of Anaesthetists. I think about 1985 it was. And my reason for doing that was my outrage that our top registrar had been failed in the examination, and we couldn't see how on earth could he possibly do that. But once I became an examiner, I could see how the best people can make a mess of things.
Yeah, okay.
But I decided to join the section then, and I became an examiner after that for some years. We were developing treatments all the time.
Mm-hmm.
What was happening in those days, you were taking on patients and you didn't know if you could do any good for them or not.
Mm-hmm.
So what I'm saying, we were trying to find our ways to what was appropriate to do and what was futile to do. The first 40 patients that Matt Spence reported on with cerebral edema, they all died, which represents, you know, they'd be a kind of patient, you get a ring from the neurosurgical unit, and they're saying, oh, you've got a patient here who stopped breathing and he's got fixed dilated pupils and we're bagging him, would you take him away? Mm-hmm. And an optimistic Matt took all of those at first till he found out that you know, that was, they were at a point of no return.
Yep. And did you continue to attend World Congresses and build up contact?
I went to the second one, 1977 in Paris, and I presented a couple of papers there. One of them was on severe or intractable convulsions, and in both 74 and 77 I went around a lot of units in Europe and gave talks about different topics, and I was seeing the tendency then, which you're talking about, it had happened a lot that they were changing from a general intensive care unit looking after everyone to cardiothoracic people saying we want our own post-operative one, and neuro people doing the same too. And at the time that seemed to me a retrograde step, though that's the way it is now.
Why did you think that was a retrograde step?
Because they may have had experience, but they didn't have enough general medical nous, it seemed to me. You know, once you become a specialist in a field, your vision gets narrower and narrower all the time.
Yes. What used to happen when you were just starting in intensive care? Who would go to the cardiac arrests in the hospital? Would the intensivists go?
Intensivists go, yes. And sometimes the physician registrar would, but we had the, as they call them, Blue 100 calls. They'd come to us. We set up a system of the alarm sounding in our unit, and we had close liaison with the ambulance people. We had communication with the ambulances in transit. Before, say, 1984 or so, the ED departments were just under the charge of a houseman and possibly a nominal sort of retired surgeon or something or other, but they weren't organised at all, and we used to get all the emergency calls down to there.
Okay, to the emergency department.
Yes, which we would welcome if we were going to be bringing a patient up to our unit, that they were properly handled from the beginning and not allowed to get worse from what they were.
What happened with the trauma calls? Did you get called down to those as well?
Yeah, routinely, yeah. And then a trauma resuscitation system was set up in Auckland Hospital in the late 1970s, and it specified members, an intensivist, a surgeon.
So that team-based approach to patient care is something we regard as fairly modern, but you're saying it started in the 70s here in Auckland?
Later 70s, yes.
So the first anaesthetics you gave were dental anaesthetics, you were telling me.
Yes. I wasn't a doctor.
You weren't a doctor, but so you were using a McKesson machine, is that correct?
I remember,
Tell us about how that worked. Do you remember?
Oh, you turn the knobs. And because they weren't intubated, you just started to get worried about the gurgling down the back of the throat.
So would you have an intravenous in at all?
No.
No. So just nitrous oxide and oxygen?
No, but some of the clearances, as the expression is, were done by the local GP coming and using a continuous thiopentone.
Okay. Okay, but as a dentist, you just give nitrous oxide and oxygen, and with a nasal mask?
Oronasal.
Oronasal, and then you take it off intermittently for the surgery to proceed, or?
Well, you'd have to.
So it was an on and off sort of situation, all or nothing sort of. Well, there's a lot of emphasis now on end-of-life decisions and end-of-life care. We're getting better, I think, at talking about it. Do you think it was well discussed when you were an intensivist?
No, not really. I think you presented the facts to the relatives, and the relatives would accept it, that was an expert opinion, that the time has come to withdraw treatment. You don't sort of went on and on until not that this happened, all that often, but it was an option that was taken up if it was appropriate that should happen. And I remember what we had then, which they don't have now, which I find regrettable, is that in the 1960s and 70s, every patient who died in intensive care, if it wasn't a coroner's jurisdiction, the relatives were always asked, we would want to have an autopsy.
Yes.
And that was the way you learnt a lot.
Mm-hmm.
You found out there were lots of things happening you didn't detect at all. And now they've lost that. They don't have such ready access to it, and it just justifies your thoughts that you're right all the time about the decisions you make.